All right, so what I wanted to try to do with this PowerPoint is essentially just run through it as quickly as possible, hitting some of the key points in about 15 minutes, trying to get you to understand the importance of some of the stuff we're talking about, but yet we'll still be able to cover 2 chapters in one day. All right, so this is a different way to do this. First thing I wanted to cover was basically when injuries occur, while generally most of the time the injuries that we deal with in sports medicine are not life-threatening, but they do require prompt care. And some of the initial management of those injuries can prolong the length of time required. So if I mismanage an athlete on the field, that could obviously alter the way that I treat that athlete or the care that I'm able to give that athlete later on down the road. All right, so we have to have an emergency action plan in place that can be implemented at any time, so as soon as something goes awry. The key to this is that most of you will be in clinics, and we've spoken about it before, but you need an emergency action plan that dictates what will happen if something does go wrong. All right, a lot of this you've probably had in CPR, but I want to make sure that we cover the key points. So the primary concern is maintaining cardiovascular and central nervous system functioning. That is imperative, obviously, when we have especially a life-threatening injury. All right, we want to make sure that we have a prearranged plan that would be that emergency action plan. So I wanted to just hit on a few of the different aspects of the emergency action plan, just so that you understand what we're talking about. Basically, you want to make sure that when something does go bad, that the person making the phone call knows and is able to relay what is happening, especially to the injured person. So we want to know the type of emergency, we want to know the suspected injury, we want to know the present condition, the current assistance being given. So is someone performing CPR? Is someone bandaging? Is someone splinting? Where is the location of the phone being used? Now that's kind of an old recommendation. Obviously most of us now will be on cell phones, so but still you want to know where you're making the call from. The location of the emergency and the building limitations. So if you're inside, is there an elevator? Is there any stairs? Is there a back door that's easier access maybe for a gurney coming off of an ambulance? So you want to make sure that everybody in your facility and all that your school administrators are aware of their roles, and they should be rehearsed. It seems kind of cheesy at the time when you're doing it, and you feel kind of stupid going through these mock scenarios, but it really does help if something does go bad. And so for us specifically from a sports medicine perspective, plans should be in place for other personnel at games, practices, other special events. The referees need to know, the spectators need to know, and a lot of times you'll hear at games the PA announcer mentioning, here are the exits, same thing like a movie theater, places like that. All right, so we have different types of injury assessments. First one I wanted to talk about is on-field assessment. This is what an athletic trainer is going to do. All right, some orthopedic physicians and athletic trainers are going to be the ones primarily responsible for the on-field assessment. This is going to determine the nature of the injury, basically provides us information regarding the direction of treatment, what needs to happen next, and it's divided into primary and secondary surveys. What primary and secondary surveys? Basically what we're looking at here is the injury has occurred. We're going to go through a primary survey. Basically what a primary survey does is establishes life-threatening injuries or not. All right, that would also be based on level of consciousness. So if someone is unconscious, we're going to go down this route. If someone is conscious, we're going to go immediately into our secondary survey. If someone is unconscious, we're going to assume that they have some sort of cervical spine injury. We're going to stabilize that injury. Then we're going to look at responsiveness, airway, breathing, circulation. Are they going into shock? Do they have profuse bleeding? We're going to call 911, and then we're going to care for that patient until emergency medical services arrive. Conscious patient, you can see, is a little different. If someone's conscious or responsive, we're going to go into our secondary survey, and we'll break those down in just a second. All right, so our different surveys. Primary survey, like I said, life-threatening condition is what we're looking for. As we go through that, that's essentially, this right here is basically your first aid CPR class that most of you should have had. If you haven't yet, you will have, but you talk a lot and you discuss a lot about this primary survey. Moving on to the secondary survey, all we're looking here is when a life-threatening condition is ruled out, that is when we are able to go in our secondary survey. So going back to that previous slide, Once we have a conscious, responsive patient, we can move into our secondary survey. All right, so we're gathering specific information about the injury here, assessing vital signs. We want to continue on with our evaluation at this point. All right, so this is a CPR slide here. Establish unresponsiveness. Life-threatening conditions. Is the environment okay? Is the environment safe? So if you have fires, if you have any sort of environment that you're going into that may still pose some sort of hazard or detriment to you, we want to be aware of that, and we don't want to enter that scene. All right. When we get to the athlete, we're going to ask, "Are you okay?" If no response, immediately you tell someone to call 911. All right. Again, this is just basic CPR. A patient that is breathing in a prone or side-lying position should be placed in a recovery position. Essentially, we want to get them to where if we do have to spine board them, that they're in a more stable position. All right, and you should go over that more in CPR. We typically during this class, I'll actually have a spine board. Maybe we'll have time to do that this semester. Maybe we won't, but that's essentially what happens there. Log rolling is how we basically get that person or that patient into a recovery position, and we want to limit cervical motion. So this is what you'll see if you have an athlete that goes down on the football field, and he's unresponsive. You'll see somebody go stabilize head and neck immediately. All the others get there. They stabilize hips, they stabilize shoulders, they stabilize knees, they stabilize ankles, and then they log roll this person into a supine position and onto the spine board. Quickly, external bleeding. A good question on the test would be, how do we stop external bleeding? And these would be the ways that we stop external bleeding. Direct pressure, you've probably seen that before. Scalp injuries are really, really bloody. The scalp is so vascular. Direct pressure is one way. Elevation is another way that we can limit or stop external bleeding. Then obviously pressure points are points on either side of the body where you're trying to slow bleeding down. On certain arteries there. And we're not going to cover that any more in depth than just knowing how to stop external bleeding. Direct pressure, elevation, pressure points. External hemorrhage, all I want you to know is that it's just an abnormal discharge of blood. All right, this is you're going to come upon a scene that where there's been a pretty severe injury. All right, this is what this is stemming from. But that's really all I want to just cover on that. Our internal hemorrhage, very much an important thing to understand, but difficult to recognize. So these are good points to know. It's invisible unless it's manifested through body opening. So really difficult unless we're doing some sort of diagnostic test. So if I have an athlete go down, I obviously cannot immediately take them for diagnostic testing. I need to do that as quickly as possible, but never rule out internal bleeding if they've sustained an injury that might have entailed some internal bleeding as well. So this can occur beneath the skin, where there's not a lot of danger, but bleeding within a body cavity obviously can be life-threatening. So if you suspect that, you need to monitor blood pressure, you need to monitor heart rate, you need to monitor their responsiveness. Are they coming in and out? Are they making sense? Color of their skin, those sort of things. So it's difficult to detect, but you need to refer if you have any questions. All right, could lead to shock if not treated accordingly, obviously. So what is shock? Just real quickly, I wanted to go over a couple different types of shock. All right, this would be on the test. Good multiple choice questions right here. So you can see the different types of shock there. I'm really not going to talk a whole lot about any of them, but I just want you to know they're there and know what the different ones are. A lot of times we'll see anaphylactic shock, which would be a result of a severe allergic reaction. That's the one we'll see the most. Signs and symptoms of shock, obviously important, so I do want you to know those as well. Moist, pale, cold, clammy skin, weak, rapid pulse. This is where it's really important that we know how to take a pulse, and increasing shallow respiration and decreased blood pressure. Really important we know how to take those. And obviously you can see the other signs and symptoms. Management of shock. If you didn't know this is really important to know as well. Again, CPR, first aid type information, but I just want to make sure we covered it here. We want to maintain body temperature. We want to elevate the feet and legs to 8 to 12 inches above heart. One of the key things I think is here is limit the onlookers and spectators. If someone is in shock and they're going into shock, it's frightening for them to see a bunch of people around. So we want to make sure that we limit those onlookers and make sure that we're constantly reassuring the patient as well. All right, secondary survey. What we're looking for is pulse. A normal pulse for athletic pulse would be around 60 to 70 beats per minute. Normal adult pulse is 70 to 80 beats per minute. We want to obviously maintain consciousness, all right, and how responsive they are. Are they alert, confused, drowsy, or unresponsive? Respirations, about 12 in a minute. Blood pressure, 115 to 75. Our standard is 120 over 80 is normal. What's the temperature? What's the temperature of their skin? Different ways to take temperature. We're not really going to cover that. But then what is their skin color? How do their pupils look? Very quickly on pupils, you can see here the difference in a dilated pupil all the way down to a constricted pupil. And constricted pupils may indicate a use of a depressant drug, but can also be indicative of a head trauma. Dilated pupils may indicate a head trauma, shock, or use of a stimulant. All right. So if we're looking at potential drug use, this is something we look at. But really, for the most part, what we're looking at pupil size is for a head injury. So failure to accommodate may indicate a brain injury. So if you have pupils here, basically what we do is we'll use this pin light. A lot of these pin lights have pupil size on the side, but turn the light on, put it in the eye, just have them look straight forward and see how the pupils react. The acronym that we use is PEARL, P-E-A-R-L. Pupils equal and reactive to light is what we want to make sure that we have there. Musculoskeletal assessment. This is what we're going to get into in the next lecture, but really we want to make sure we have a history. You want to make sure you have visual observation, and then obviously we need to splint. You should always splint a suspected fracture. If you cannot rule out a fracture, you need to splint. You need to splint that fracture. Different types of splinting, but if you don't have proper immobilization, obviously you can damage that injury even worse. It's a simple process. Newer splints like these here are vacuum splints, so you can kind of see the end of the vacuum here. It's basically this is filled with foam pellets, and we're just taking the air out with this vacuum here. It's a hand vacuum, and that will just make this really rigid to where this lower leg ankle area can't move. All right, those are called rapid form immobilizers. All right, then we have a SAM splint. This is the oldest picture I could possibly find on the internet, but here I think it said it from Zombie Hunters. Interesting. Anyhow, these splints here are just semi-rigid aluminum splints that you can obviously see are, you can put these anywhere on the body. Wrap those with an ACE bandage or any sort of wrap that you have. ACE bandages usually work the best. If you have any sort of Velcro wraps, even roll gauze, if you're in some emergency situation, didn't have that, would be good as well. Spine boarding, all I want to cover, again, this chapter is really good because usually we cover some spine boarding, and again, if we find that we have some time, we'll do this in class, but one person must be responsible for the head and neck at all times. So as I said, if we suspect a spinal injury, all we need to do is get down there. The person who stabilizes the cervical spine is at that point in charge for the duration of the spine boarding. All right, moving and transporting an injured patient. You just need to be really careful. All right, this is something that during your emergency action protocol would need to be covered, and the more that you practice this, the more comfortable you are if in fact you need to do this. One of the last things we want to cover is proper fit of crutches. All right, really all I want you to know on this is a patient should stand with good posture and good shoes, but the crutches should be 6 inches from the outer margin of their feet, so 6 inches out, and 2 inches in front of the shoe. That is proper fitting for crutches. All right, and then this will be on the test as well, so I want you to think through this. Crutches on stairs. If you're going upstairs, lead with your good leg, then put up your crutches. So going upstairs, lead with a good leg, then put up your crutches. Going downstairs, it's crutches first, then the good leg. All right, so it's opposite of that. All right, these are the stations we normally do. Obviously, we aren't doing those today, but that's basically what I wanted to cover. So really, really quick, ton of information. I know I covered that really fast, but I wanted to hit on those key points. So go back and review this if you need to, but that is basically what we're looking for with assessing the situation. All right, and that is a pretty nasty tib-fib complete fracture there on a triple jump. So hopefully you never see one of those.